agenda, as you can see, we have a few items we would like to cover today, including the leadership group, some membership statistics, the highlights for the community at the Toronto Symposium, planning for the 2027 symposium, which will be held and will be a true highlight since it will be held in Sydney in Australia. And it's a great pleasure to have two guest presentations today. The first one will be given by Dr. Colleen McIlvaine and the second one by Dr. Joseph Rogers. And of course, we will have some time for questions and discussion. Which brings me to say a great thank you to the nursing and allied health professional community representatives for this term 2025-2026, including those people which are listed here and can be seen. And I hope that some of them will be able to join us and say hello to us today. I have seen that Rebecca is joining us, and since she will take over the gavel and will follow my position being the chair for the 2026-2027 term, I would be happy, Rebecca, if you could say hello and introduce yourself.
Yes, I will even turn my video back on. Although in this getup, I don't look anything like that photo. So, well, thank you very much. I'm super excited to take over this role for the next year. I've been in nursing for several years in the capacity of first a bedside open heart recovery room nurse, and then went on to grad school to become a nurse anesthetist, and then more recently, kind of changed gears a little bit and went back to complete my doctorate degree and now lead the cardiothoracic and vascular division at Mayo Clinic, Florida, as well as quality and research for our department. I've been a member of ISHLT since 2021, and I have to just say, when I first joined, I was just blown away. I'd never been part of an organization that, truly appreciated all of the multidisciplinary facets of care of taking care of, the patient with advanced heart or lung disease. So I'm excited to work with you all, and I'm super excited to see what we can accomplish in this next year. So thank you.
Thank you so much, and thank you for stepping in being our representative for the upcoming term. I also would like to take the opportunity to say a wholehearted thank you to the entire group and everything they have done to support our community during this last year. So thank you to all of them. And I have the pleasure to say hello from Thomas Schluckelhofer, who was not able to join us today. Which brings me to take a look at some membership statistics and the distribution of our professional community. As you can see, the Nursing Allied Health is representing 9% of the entire community, meaning that we are being the fourth largest group within the ISHLT membership. And zooming in on the numbers a little bit, you can see that looking at the membership types, we are represented by the non-physician chart pie piece. And looking at the region, of course, the majority of our membership, the entire membership demographics, is represented by colleagues from North America, followed by the European membership, and the third largest one is the membership in Asia and Oceania. So that area where ISHLT will take its foot on for the 2027 symposium. looking at the internet disciplinary network, you can see that our community can be represented in all of those groups. Which brings me to the symposium itself. And first of all, I would like to take this opportunity to say thank you, a wholehearted thank you to the program planning committee for this upcoming symposium. First of all, our president, Joseph Stelick, and the program chair, Caroline Patterson. A special thanks to the incoming chair, Dr. Melissa Casino, since she will be the chair for the 2027 symposium and will be a representative of our community. Also, a wholehearted and warm thanks to Sabina de Giest and Sarah Schroeder. They did represent our community on the planning committee for the upcoming symposium in Toronto. For the Toronto Symposium, registration is already open, so don't wait, since the registration fee will be reduced until April 1st, giving us all a chance to register early and benefit from this reduced fee. Also, since this is, for the majority of us, will be an international symposium, I would like to let you know that it will require either a visa or an ETA, an electronic travel authorization, to enter Canada. So to be sure that you apply quite in advance for either a visa or an ETA in order to join us and to be allowed into Canada. To take a brief look on the program schedule for the Toronto Symposium, please note that there will be 5 overall, there will be 5 pre-conference workshops, which might be attractive to our community. So please spread the word and let your colleagues know that if they are interested in participating in one of those pre-conference workshops, they need to register separately. Looking at the symposium itself, it will be quite an exciting one, since overall there will be 77 educational activities which relate to our professional community, which of course will include the plenaries, but also symposia, oral and poster session, and something which will be special and new this year, which will be a featured Nursing Allied Health poster session, something we will try for the very first time and look forward to hopefully a well attendance of this special session. It's never too early to start planning for something. So we would like to take this opportunity today to call out to start preparing for the symposium in Sydney 2027. And here we have depicted the timeline and key dates for the planning. Since the symposia submissions for symposia proposals will open already June 1st. And we would like to continue to something we have established during the last term, which was that we offered for our community 4 symposium development sessions. So just informal gatherings which have been held virtually, to have our group offered a platform to exchange ideas, to share ideas for symposia, to have drafts being presented and reviewed, to look for potential speakers, to take note of the 3Gs. So to really share experiences, share ideas, and support each other for symposium proposal developments. Also, I would like to note that there is an online presentation which is available to all of us, which is focusing on how to present to make it easier to be prepared for a presentation at the annual symposium. And it might be helpful specifically for those which are less experienced. Looking into the future, I would also like to take a minute to look into the past and what happened, what we got accomplished during this last term. We had our professional webinar, which has taken place in September with quite a low live attendance, but quite a fair number of attendees which have taken the opportunity to look at the webinar being placed on YouTube for view. Also, it's a pleasure to acknowledge that for the standards and guidelines, nursing and allied health has contributed an expert consensus statement, which is on the way to be published very soon, focusing on a gap in the literature and will fill this gap, which is on social support systems in patients being considered for and followed by advanced heart and lung surgical therapies, and which is led by Dr. Colleen McIlvanen. And we are so happy that you're able to join us, Colleen. Thanks for coming. Also, I'm happy to announce that the palliative care statement, expert consensus statement, hopefully will be finished by the end of March and can go into peer review so the publication can appear soon in the Journal of Heart and Lung Transplantation. Also, our community was able to contribute even to two special issues being published, having been published already, the first one and the second one will be published in the journal Heart Lung Transplant Open. So the first one was on pediatric thoracic transplantation. It was a special issue with participation from the nursing allied health community and has been edited by Estella Ezeka and Christian Benton and was published in May 2025. The second one is a special issue with editors from Nursing Allied Health representatives, so Thomas Schlegelhofer and Sarah Shetler, focusing on MCS patient management and optimization, and will provide us with a special allied health perspective. And we do look forward to that special issue being published, hopefully in this year. Also, it's a great pleasure to announce a first special interest group being underway. And let me take a look, because the person who will lead this group and wants to join us today is Dr. Brittany Coons. Was she already able? I can't see her.
She unfortunately is not on right now.
Okay, so maybe she's able to come later. She was on lecturing duties today and said she would hope to come and join us as soon as possible. And if she comes, perhaps she can introduce herself and provide us with some more thoughts and insights on this very, very exciting project for the future. Also, I would like to announce the 2025 ISHLT Consensus Conference during the Boston meeting on the very important topic of the evolving role of nursing professionals in thoracic transplantation. Thanks to the great co-chairs, which have been Bernie Coleman and Angela Vallecca, the manuscript draft is already finished and is on the way to peer review or perhaps even under peer review right now, so that we can await its publication, since this is a topic which will fill in a gap and is a highly needed topic. So thanks to those two for taking on this huge task to set up this conference meeting and prepare us with some information on this very important topic. And now it's time to take a look at you and to give you the voice and ask for ideas for what you would like to see for your clinical practice in the future with respect to standard and guideline projects. Those can be new consensus statements or guidelines, or even consensus statements or guidelines which are available and where, with your expertise and your clinical practice eye, you would say that's a statement, that's a guideline which is no longer completely up to date, so that needs to be updated. So any thoughts, ideas, expectations to the society from your side?
Christiane, Brittany has joined.
Oh, perfect.
Yeah.
Hi, Brittany.
Hi, how are you?
Great, great seeing you. And perhaps if you have joined us, I moved over that slide introducing you and this great SIG which is underway, and having us, or you having us. So can you provide us with some more insights?
Sure. Yeah, so we're still working on getting this up and running. We had a small focus group meeting in the beginning of January to kind of generate some ideas about maybe future presentations and how often we want to meet. So I am working with Nikki now from ISHLT. We're going to try to identify a day and time for a reoccurring monthly meeting so people can kind of just expect every Tuesday at 2 o'clock. I made that up. That's not formal yet. Just so that, we can kind of keep the cadence going for things and moving this forward. But we had a lot of great discussion. A lot of people are willing to present. So eventually, once we get a date lined up, a reoccurring date and time, I'll probably send out a sign-up sheet for people if they have topics of interest related to caregiving and social support that they'd want to present on. They can come and do that informally. So some of the topics that we had talked about is thinking about dyadic recruitment and transplant, using established theories and how we apply caregiving theories to conduct caregiving research in transplant and MCS populations, thinking about caregiver interventions, maybe having some clinical case studies that were particularly challenging for different centers and how they worked through those, how decisions were made, what support was in place and provided to the support networks. We have some about what resources are available for patients and caregivers at different centers. So really from a clinical perspective, we have someone who's potentially interested in presenting on peer mentorship programs. We'll have some pediatric focused topics. There was some discussion about potentially having a patient panel and asking them, what are their expectations from their caregiver as they're entering into transplant, and then also having a caregiver panel about what are their needs and what are their expectations. So we have a lot of really cool topics lined up, and we're going to try to do this monthly. And then we have some other things we'll try to work on that we talked about, like developing at least one symposium for the ISHLT 2027, and then future meetings moving forward. So we'll start to work on that hopefully this spring. So we're ready to submit something in June. There was some discussion about potentially developing a masterclass focused on this for the future. There was some discussion about developing an international survey of social support assessments and interventions that are currently in place at different centers. Maybe we'll try to write some papers together, maybe do some journal reviews to review some literature and how to critically appraise that literature. So lots of really cool, fun things for us to get together and talk about transplant caregiving and MCS caregiving. So we're going to try to plan our first meeting maybe March, or maybe we'll wait till after the annual meeting. So just keep a lookout. Join the SIG. There's an option to join this caregiving SIG on the communities within ISHLT Connect. So we have 56 members signed up right now. So if you're interested in this, please sign up for that. And then we'll post our future plans in there. And I'll probably post something on the nursing and allied health professional community also, just in case people are unaware of the SIG, just to pull more people in, but what our future plans are. So more to come.
Great. Thank you so much. We do look forward to it very much. Let's go back to future ideas for standard and guidelines, and also, of course, for the next webinar. If you have ideas, perhaps use the chat. Present your ideas, contact us, contact the ISHLT staff. So deliver your ideas so that ISHLT can work on it for the next term. Which brings me to introduce our guest lecturer today, which is Dr. Colleen McIlvanen. She's a PhD and a DNP and an advanced practice nurse and a professor of medicine at the University of Colorado. Dear Colleen, dear Dr. McIlvanen, please take the podium and present on the engagement of social support systems and patients being considered for and following advanced heart and lung surgical therapies. Thank you for coming.
Great. It's so great to be here. It's really great to see so many familiar faces, but also new faces. And Christiane, if you're okay, I'll share my slides. And just to know, this is a preview. I am presenting on behalf of my co-authors. We are currently responding to our initial set of peer review comments, which included 12 peer reviewers. So it took a while to get through all of the comments. So we are hopefully submitting those in the next week. And we'll see if we'll have another round of comments, but then we'll be submitting for publication. So I just cannot thank this group enough. We had 6 amazing individuals that were our leadership group. Samantha's on the call today, but I have worked with them now over the last 18 months, and it has become just a really great group to work with, and I cannot thank them enough. We also had a writing committee of over 20 individuals that put in a significant amount of work for their sections. We were really, really intentional about who we included in this writing group in order to provide broad representation. As many on this call know, the social support systems really encompass not just the caregiver, but all of the other supports that patients need to get through advanced therapies. And we know that it's not standardized. I mean, it's not even standardized among programs, much less continents. So we made sure that there was representation from all IDNs, the Advanced Heart Failure and Transplantation IDN, Advanced Lung Failure and Transplantation, MCS, and PH. We also had broad geographic representation, and for some reason, the flags didn't line up exactly where they were supposed to, but we really tried to ensure a broad swath and ensure that everybody had their input specifically to their current recommendations around social support. And then last, we had really broad professional representation. As we know, this is a team effort. It is not led by one specific profession. So we had physician representation, we had nursing representation, advanced practice providers, PhDs, occupational therapy, psychology, and social work. So I'm going to start this with actually a patient that we cared for in 2025 at our center at the University of Colorado. So this is Mr. JB. He's a 66-year-old male with longstanding idiopathic dilated cardiomyopathy, EF around 20 to 30%, and VT. His HFrEF actually was managed at a referring clinic who we work really closely with. Their advanced heart failure and transplant trained APP as well as physician. So they referred him, since he was not tolerating up titration of his GDMT back in 2024. They referred him early, but unfortunately he was deferred from our program for inadequate caregiver plan. Our specific requirements are a dedicated caregiver or caregivers for the first 3 months post-heart transplant. He had worsening heart failure and VT over the summer of 2025, and we reinitiated a heart transplant evaluation at that time. For his social history, again, really no medical contraindications, but his social history, he had no drugs, tobacco, or alcohol. He was insured and received small Social Security income. He worked as a photographer and was frequently traveling to Ukraine. He carried the label of housing insecurity and stated that he had a lot of friends, but no family. Our transplant social worker, who we have two who are just phenomenal, met with the patient multiple times during the course of his transplant evaluation. The first visit, the caregiver did not show. The second visit, a different person showed but declined to function as a dedicated caregiver to help with transportation and care post-transplant. So the patient was told he could not be listed without a caregiver. And again, this is not an uncommon situation. I think in a lot of programs, certainly many programs do not have caregiver support requirements, but that's really why we delved into the consensus statement. So the goals of our consensus statement were twofold. So first was to summarize the current state of evidence and practice regarding social support systems, including caregiver roles for patients undergoing evaluation, treatment, and recovery from advanced heart and lung surgical therapies. And second, our goal was really to provide consensus-based recommendations to guide programs in effectively assessing, engaging, and supporting patients and their caregivers in order to optimize adherence, recovery, and long-term outcomes following cardiothoracic transplant or LVAD implantation. Now, this may seem like a lot. We really did span all of the advanced therapies. We really focused on heart transplant, lung transplant, and LVAD implantation. We received a lot of feedback from the Standards and Guidelines Committee around our proposal, and they really wanted it to be all-inclusive instead of dividing it into papers. So the statement does cover really a broad representation of these patients. What we first needed to do, though, was to define social support systems. Again, we were intentional about the use of the word social support systems. We did not use the word just caregiver, which again, we could talk about, and Kathy's on the call and Brittany's on the call. And I think there's a lot of, really healthy debate, I think, around the term caregiver and what we can use instead, such as care partner. But really, we define social support systems as a network of individuals and resources that provide medical management, logistical, emotional, and psychological assistance throughout the treatment journey. So this is our figure one. We really showcase the patient at the center along with the caregiver, but this can also include friends, neighbors, community members, faith communities, governmental, social service, and insurance resources, support groups and mental health resources, and healthcare teams. I think notably, though, for this statement, most of the data is really around the specific caregiver role. So a lot is focused on that, but really we were intentional about being all-encompassing. So what we did first was turn to the guidelines, and actually ISHLT is at the forefront of these guidelines. Most of the guideline recommendations are all ISHLT statements. The guidelines really state that insufficient or inadequate social support may negatively affect patient outcomes across patient populations receiving advanced therapies. And although many programs require the identification of a dedicated and capable caregiver, not all programs across the globe endorse this criterion. I think our group, what we found is that the current guidelines do not provide specific recommendations endorsing this requirement. I think, even the updated MCS guidelines really did not change the wording around assessing for caregiver burden, and that may be a contraindication to pursuing MCS implantation. So what our group really wanted to come out and say in our consensus-based document was that the assessment of social support should focus on a strength-based approach and aim to facilitate rather than deny transplantation or LVAD implantation. And I think this was really our guiding principle. Again, where there is not enough data for us to come out and say programs should absolutely require a caregiver for 3 months post-transplant, but we can provide strategies of how we can support programs and specific caregivers as well as social support systems to lead to positive outcomes for patients. We also looked at psychosocial caregiver evaluation measures. I listed a few here that are commonly used. Again, there is not enough data out there for us to come out and recommend one specific evaluation measure for programs to use. However, we did want to highlight specifics that other programs do use. What we did find, though, and there's data missing, and that few of these tools really focus on the caregiver specifically. And most programs really do rely on informal assessments conducted by the social work team to assess caregiver burden, and rarely follow caregivers longitudinally. So again, identifying the gaps in the literature was equally as important to us in this consensus document as it was providing recommendations. We also wanted to highlight the different types of support that the social support systems provide. So I won't go through this slide in detail, but we really focused on emotional support, informational support, instrumental support, and companionship support that is provided to the patients going through this. Next, we really looked at caregiver outcomes in advanced heart and lung surgical therapies, as well as patient outcomes and dyadic outcomes, which there are minimal dyadic outcomes that have been assessed in this population. For caregivers specifically, we looked at multidimensional burden, psychological health, physical health, health-related quality of life, and as well as satisfaction and reward, which is something I think we should make sure to highlight in this population. And last, we really looked at intervention studies, which, to be honest, there were only 14 when it came to studies that focused on social support systems and any intervention that was aimed at improving either patient or caregiver outcomes. Interventions focused on education, mental health, social support, and quality of life outcomes. And overall, actually, the findings indicated positive change following intervention. But as, again, probably most people on this call know, the studies were really limited by their methodological heterogeneity. Almost all of them were single center studies. Small sample size is very few randomized design. I think only 1 or 2 off the top of my head, and really lack of generalizability given these methodologic discrepancies. So that leads me to our consensus recommendations. And I don't want to get into this too much, but we have a really great table focused on these consensus recommendations, as well as strategies of how programs can help promote them. But ultimately, our group, given the data, given what we know, given the anecdotal data that we have as experts in the field, we really felt that there were 6 recommendations we wanted to focus on with this population. And the first was to identify and engage caregivers early in the evaluation process, deliver targeted education and hands-on skills training. There's actually some really great data from Northwestern around VAD hands-on skills training, building peer connection, integrating caregivers into clinical workflows, embedding palliative and psychosocial resources, and systematically assessing caregiver needs and risk for burden, and refer to appropriate resources. What we found was there's a lot of future work to be done in this area, and highlighting this here broadly, we really felt that investigating the relationships between patient recovery, caregiver experiences, and caregiver and patient outcomes really would help identify where interventions are most needed. But then we need to develop interventions and test these interventions to engage and support specifically caregivers, but as well as the social support systems. What we found is that adequate social support is not identified well. It is broadly defined, and each program really defines that individually. So it would be great to establish a more structured recommendation and have that specifically linked to outcomes, which is where we're missing a lot of this data. We need to conduct prospective longitudinal studies that to inform the trajectories of caregiving. We all know there are intense periods of caregiving and maybe plateaus, but how do we help support caregivers through those different trajectories? And then last, exploring caregiver experiences and outcomes in subgroups of caregivers. As again, most people on this call know, given a lot of the evidence really now stems from spouses or partners. In the pediatric space, it is often mothers or parents, but we really need to broadly look at the differing experiences that people have that provide this support. So just to wrap up, our patient, JB, actually was transplanted. It's an interesting story. A nursing student that was rotating in our cardiothoracic ICU heard about the fact that he did not have a caregiver and offered for him to live with him and his wife and to be the dedicated caregiver. So JB was transplanted in September. He's done well. He has stayed with this nursing student and his wife over the holidays. And actually, as of May of this year, he is asking to move back to Ukraine, but is currently living on his own. So I just want to, again, thank my co-authors. This could not have been done without all of you. It was a tremendous amount of work and effort. And I am really hopeful that we are putting forth something that is useful to the community. And I look forward to anybody who is willing to share any comments or happy to take any questions.
Thank you so much, Colleen. Any questions, thoughts?
Great job, Colleen. You were a great leader throughout this. Excited to see this published. So what are we thinking the timeline is? Like you're submitting the comments for the reviewers soon, and then when can we expect to read this in press?
Yeah, so I hope so we had 12 reviewer comments or 18. It was a lot. So we're hoping to get those submitted next week, and then it will depend on if we go through another round of peer review at that point. And then I would say submission to JHLT after that.
Great.
Kathy? Dr. Grady? I guess you are muted.
Darn it. Okay. One more time. Colleen, you've done a fabulous job leading this group. It's incredibly important. I think we all know that. And I think caregivers in the future will appreciate all the work that will be done. I'm with you, we need more intervention work to help caregivers out. And I think you are bringing this to the forefront. And I look forward to the publication. Huge congrats to you, to your co-leaders, and the whole team. Great.
Thanks for all you've done, Kathy and Brittany, putting this forward.
Okay, thank you so much, Colleen, not just for presenting, but being such an excellent leader and pushing this project forward. Thank you so much.
Yeah, thanks for having me.
Thank you. And I can see that Dr. Rogers already joined us. So, Dr. Rogers, thank you for coming and introducing us. So, being the new editor-in-chief of the journal Heart Lung Transplantation, please provide us with some insights about how to publish in the journal so that the community can be seen in the journal. Thank you so much.
Christiane, well, so first, thank you very much for the kind invitation to join this group. It means a lot that you would think to reach out, and you're very kind to note that I'm the new editor-in-chief because I've actually been at this for a while now. I would say I'll just make a couple of quick comments about how the journal's doing. It's always a little bit hard to know because we're used to looking at the impact factor, which is looking at the last 3 years. So in July, I'll have been at this for 2. So a lot of what we're looking at in terms of impact factor still is looking back at the old editorship and sort of the change that occurred with the journal, where Daniel Goldstein was very much focused on trying to get more basic science papers. I think we've flipped that a bit. We're back to publishing many more clinical papers because I think that's largely what the readers of the journal like. And if you look at some of the leading indicators, Christian, that they look good. So, and the data from last year showed that our submissions were up by almost 40% compared to the year before. And if you use the first 6 weeks of this year as what's going to happen in December, we're probably going to be up another 30. So when I took over, we were taking in about 800 or 900 a year. This year it could be 1,500. So we're getting a lot of papers, which is great. We're not increasing the number of papers that we're planning to publish. Also, a strategic sort of move. Remember that the impact factor is the number of citations in the numerator and the number of pages you publish in the denominator. So, I think what we're really doing is getting some outstanding science being published. And we're sending a lot of the papers that we don't accept to the open journal. So I think it's really nice as the editor of JHLT to have that outlet for what I think now are very good papers that should be published. We just don't have the room to publish them. I think so. I really enjoyed Colleen's comments. The paper that you're going to submit to JHLT, thank you, is an important contribution. But we would welcome any sort of meaningful, high impact submission from any of our professional communities and from any of the interdisciplinary networks. So the hard part, I think, is just trying to figure out what science you're working on that's going to be high impact. And we're getting to the point that, like I said, where we have this luxury of publishing really high quality papers in the journal again, which is exciting. And I think what we'll see is, the increase in the impact factor going forward. The one thing I will tell you that I think is an advantage to submitting papers to JHLT now, and that is the turnaround times are way down. So the time to first decision for all of the papers that come in is just a hair over a month. So, so the promise I can make you is that you will get a review of your paper, you'll get it fast. If the decision is made not to accept it, you'll get that answer quickly with some rationale about why, but it's not going to sit in a queue and wait for, a couple of months. That just doesn't happen anymore in the journal. The other thing I'd like to highlight for you is that we're running 3 simultaneous editorial boards. And what I try to do is send papers from the European countries in the Middle East to a European editorial board, the papers from North and Central and South America in the Americas editorial board, and papers from the Asia Pacific to that board. Because I think there are regional differences in what communities find important. And the things that I think may be important sitting here in Houston, Texas, may be very different than the things that are important in Warsaw. So I think that there's actually data to support this sort of approach. So all I can do is promise you a solid, fair review, a quick turnaround time, and I would welcome, sort of high impact papers coming from this group. And I'll pause and answer questions.
Thank you so much. It seems that culture plays a role in all of our day-to-day work these days. So in the social support paper, I did hear a lot of cultural issues. For the journal, 3 editorial groups located, one in the States or one in North America, one in Europe, one in Asia. So culture coming into play, and for the clinical practice probably as well.
Yeah. Well,
Dr. Grady, sorry.
Hi, Joe. Thank you so much for joining us and sharing. Could you provide maybe a few more thoughts? You speak to high impact manuscripts coming in. Could you sort of thinking about study design, everything from qualitative to randomized controlled trial, single center, multi-center, whatever. Can you talk a little bit more about really high impact, strong designs that would be welcome?
This is exactly the question I figured that you would come up with, because it's very insightful, Kathy, honestly. It's interesting because the papers, if you just compare the papers that come out of the US compared to the papers that come out of Europe, they're very, very different, right? So in the US, we're getting a lot of large database analyses coming out of the UNOS data set. In Europe, I get a lot more single center translational research, basic animal research. We get almost none of that from the US. So it's been very interesting to watch how the different regions approach their research questions. And there's not, one is not more valuable than the other. They really complement each other so nicely. I think a lot of what we're publishing now is quantitative science, which is, it may or may not align with some of the work that comes out of this particular professional community. But it doesn't make it any, the work that you all are doing, it doesn't make it any less valuable. And so I think when we get a good paper, we try to send it to individuals to review that paper who have a like research portfolio, so that they have an understanding of the work that's being done and how complicated it is to get that kind of research completed and published. But, I think in terms of the question you're asking, an interesting question, a sound scientific methodology, presented well with reasonable conclusions, and we're all in.
Thank you.
Of course, just exactly the politically correct answer that you would expect from an editor of the journal.
But a good answer.
Thank you so much. Other thoughts or questions to Dr. Rogers?
Yeah, I would just one more time would say, getting a transfer recommendation, a transfer decision to the Open Journal is not a loss anymore at JHLT.
Yes.
It just, we are taking well less than 20% of the papers that get submitted now. So it's it's nice to get published. I like to keep papers in the JHLT family of journals is kind of my motto here.
Yes.
Yeah.
I have a quick question. I think it was in JHLT Open where we had, there was a special edition focused on nursing and allied health related to VAD, I want to say. Do we have any plans for that in the future, either with JHLT or Open, where we have these special editions that might be more focused for nursing and allied health?
Brittany, great question. So we have, I don't know what Dirk's doing. So we don't talk all that much. And it's not that I don't love Dirk, but we just don't do it. So we have two very separate strategies. We have decided this year, and we've implemented it, we're going to do quarterly special issues, and we selected the special issue topics. None of them were specifically nursing related, but the first one was on novel therapies in device therapies in heart and lung failure. Then this one that's open now is for PGD in both heart and lung. And you may have papers that would fit in really nicely to those. The next one is getting ready to come out. I can't remember what it was, actually. I'm so sorry. But anyway, we've got 4 scheduled this year. The other thing we're doing is we're doing a monthly commissioned state-of-the-art paper. So I think some of those are could be potentially related to the nursing and allied health field, but not specifically focused on that. I mean, what we tried to do with all of those is come up with a broad topic that our entire readership will be interested in. So
That makes
you're
sense.
absolutely welcome to submit papers to the special issues for sure.
Great.
Yeah.
Thank you.
Great offering. Thank you so much. Any other thoughts you would like to share? If not, I guess our time is almost up, so it's 8 p.m. at least for my time here.
I always have
Thank
more
you.
questions. I have one more.
Yes, please.
How can we work on trying to improve visibility for nursing and allied health? Because even with this town hall, I ran from a lecture to here and was trying to find the link for it, and I couldn't find it on ISHLT Connect, or I looked under the events page. It wasn't listed under there. And we don't have a ton of people who have joined today. And I just don't know if that's because they don't know about it or how to access it. So I'm just wondering how we can improve engagement and visibility for the professional community.
I can answer that. Promoting the town halls is a top priority, and we're actually right now coming up with a bunch of new plans, because you're right, you couldn't find the link in an intuitive way, and you should be able to. So that's going to change, and not just for nursing and allied health, but for all of the communities, of course. In terms of promoting the community more broadly, I think that posts on ISHLT Connect, whether it's in the nursing and allied health bulletin board area, or in the open forum, or in one of the IDN areas, heart, lung, MCS, PVD, those elevate the community, and whether you're posting a question or a survey or a comment or a job opening or anything, it's really helpful to put stuff out there. And I will say, it's the nursing and allied health group on ISHLT Connect is pretty quiet. It's pretty quiet. And so I would enlist your help and the help of everyone here on this call to post a question, even if it's a plant, just we want to get people talking. And I think that a lot of it it's not that people don't have anything to say. They certainly do. This is ISHLT members are passionate, and they never turn it off. I know this. But I think that there's a little bit of bashfulness or insecurity about posting. Is this okay to post? Is this the right question? Will people think the wrong thing? And so we really need to lead by example there, and just put things out there. Introduce yourself. We're trying to get people to introduce themselves when they join the organization. We welcome new members each month with a post on the ISHLT Connect group. And you can post a response to that and say, hey, welcome folks. Tell us about what you're interested in. All of those things will elevate make more noise. And that's really what we want to do. Thank you for asking.
Great. Thank you.
Okay, so thank you so much to all of you for joining us today. I'm wishing you a great